Okay. All
right, welcome everybody. My name is Elaine Scallon. I'm the co-director of the Colorado Integrated Food Safety Center of Excellence. And I'd like to welcome you all here today, both in person and online, to our quarterly food safety seminar. So today's seminar is going to talk about legal issues in outbreaks and surveillance. We often talked about outbreak investigations being like a three-legged stool, that there's like three dimensions to an investigation: epidemiology, environmental health, and the laboratory. So we have two of those legs or dimensions represented here today: epidemiology and environmental health, and we're going to talk about some of the legal issues that pertain to each of those disciplines. So we have two speakers who are both very experienced in investigating outbreaks, both in Colorado and multi-jurisdictional outbreaks. Alicia Cronquist is an epidemiologist at the Colorado Department of Public Health and Environment, where she manages the Foodborne disease program. In her spare time, she also co-directs the Colorado Integrated Food Safety Center of Excellence, and I'm sure is familiar to a lot of you because she is adjunct faculty here at the school and has taught at a number of your classes, I'm sure. From the environmental side, we have Lane Dreger, who is the coordinator in the Consumer Protection program at Boulder County Health Department. So together, a lot of experience in investigating outbreaks and a lot of good stories to tell, I'm sure. So with that, I think I should end and introduce our speakers.
I think so. Well, thank you for coming and welcome to those on the web. So Alicia and I want to talk about kind of the backbone of the work we do, and I guess the authorities that are given to us at public health, both at the state and local levels, for routine work that we do, and then obviously when we get into investigations for outbreaks, we can invoke some other powers when needed. But we really want to have this be interactive, so at the end we certainly hope you've thought of a lot of questions, both on the web and the folks that are in the room, so please feel free to ask those. And we're going to share kind of each of our perspectives, so we're going to take turns kind of doing this today, but I hope you enjoy this. And again, if you have questions, write those down so that at the end we can have a good interactive session.
Okay, so we need to figure out how we do this. There we go. Okay. So we want to do three main things today. We obviously can't cover every detail and every nuance of legal aspects in 40 or 45 minutes, but what we want to do is walk you through routine public health actions and the authority to do them for a routine environmental health inspection, which prevents foodborne illness, routine disease surveillance, and then walk you through a real outbreak investigation and control measures and what legal duties and authorities we used. And the caveat to this is that this is all in Colorado. And so if there are folks from other states, obviously the people in this room are all from Colorado, but if there are folks from other states on the phone, I want you to be aware that each state has different laws and regulations for communicable disease and environmental health. And so there might be some similarity to what we're talking about in other states, but this talk is very much focused on Colorado. Okay. So the first thing is that there's no single set of laws or regulations that are designed to protect our food system and cover everything that we eat, or how we detect those issues when our foodborne illness prevention measures break down. There are federal, state, and local agencies that are involved in food safety, and each of those operates under a variety of laws and regulations that we'll describe today. And so some of the agencies most in charge of food safety in Colorado are listed here, with the Food and Drug Administration, the USDA, the State Health Department, and local public health agencies, and Lane is representing Boulder County Public Health. But before we get into the meat of today's talk and we talk about Colorado specific, what I want to do is talk a little bit about the federal authority to do food protection and disease prevention. There are two major agencies associated with food: the Food and Drug Administration, or the FDA, and the U.S. Department of Agriculture, or USDA, specifically has a public health agency within it called the FSIS, or the Food Safety and Inspection Service, which is the public health authority of the USDA to protect food. That was interesting. But then to complicate things, it's not just the FDA and the USDA. There's a dozen other agencies with specific niches, such as the Agricultural Marketing Service, which regulates organics, the Environmental Protection Agency, which regulates pesticides and how much pesticide can be in our foods, the National Marine Fisheries Service, which regulates shellfish, and so on. Turning to our two major food safety agencies, the FSIS and FDA regulate the production of food, and each operates under the authority of several federal laws, which then have regulations. And the specific rules and authority varies between these two agencies, but both of them strive to ensure that food is produced in a safe manner and is properly labeled. So both the production and the labeling is very important for each agency. Each agency can make rules that producers must follow, can inspect, and can take action against a producer to prevent illness or in response to an illness, such as a recall. Both can perform traceback and traceforward activities when contamination is known or suspected, as in the event of an outbreak. And this authority comes from the federal government's role in regulating interstate commerce. So products that are made and consumed only in Colorado or only in one state generally don't fall under FDA or USDA regulation. So that's an important concept. So also, when it comes to food safety, it's important to note that CDC doesn't play a regulatory role. They assist states with disease surveillance and outbreak investigation. They certainly assist states with funding to do all of that, but they don't have laws or regulations that specify how that disease surveillance or outbreak investigation works. And then the USDA and the FDA also have specific areas of food that they regulate. USDA regulates when you think about USDA, it's usually meat. So meat, poultry, catfish, and then of all things, pasteurized, liquid, or frozen or dried egg products. The FDA regulates shell eggs, produce, dairy, seafood, processed foods, and anything else that the USDA doesn't regulate. So that can be a little complicated too, knowing who to call sometimes. But the rest is left to state and local agencies. So this includes restaurants and grocery stores, hospitals, nursing homes, schools, and child care centers. In Colorado, those inspections are conducted by a blend of local and state agencies, depending on the county in which the facility is located. But it's not total chaos. They don't all make their own rules. So there's a Food and Drug Administration Model Food Code, which serves as a guidance document to help make the rules for food safety regulation and to make sure that the rules are consistent to some extent across all states. And every state adopts its own version of the Model Food Code in order so that there's some consistency across states and consistency with national food regulatory policy.
Right. So as Alicia said, we're going to really focus on what's happening in Colorado, but we'll give you at least some framework that really applies across the country. So again, as Alicia said, each state will pass its own set of laws and regulations, but they all have a very consistent framework. And really it's really based on, again, laws or statutes and then regulations. So statutes can be at the state or federal level. So these are laws that are passed by Congress and then are focused on public health in our world here. And typically those laws then empower rules to be put in place, very specific to whatever subject matter. And so today we're going to really focus on food safety, so those laws that have set in place protections for food safety. These also really set who the administrative agency is. So in this case, Alicia represents Colorado Department of Public Health and Environment. So our food safety laws, typically that is the state entity who's empowered to put those in place. And then there's also abilities for them to pass on those authorities. The Colorado Board of Health is one of the entities that's appointees where a lot of the state rules and regulations are officially adopted. So the state health department would typically undergo a stakeholder process to formulate rules, and then those would be adopted by that Colorado Board of Health. And then conversely, at the local level, local regulations are adopted by local boards of health. Do we accept these ones? Okay. So one of the main laws that we deal with in Colorado is our Food Protection Act. And this is, again, a Colorado law that sets forth the ability to have regulations to govern the safety of food. It gives a scope of who is covered by that. These rules obviously do not pertain to people's home food safety. This is really at a retail level, so food that you're buying at restaurants and grocery stores and other places that are serving the public. It gives a number of authorities to the state. One, to create a license program. So restaurants need to have a license in order to sell food to the public, and it defines who needs to get a license. Gives us authority to resolve complaints. So if the public has issues and they're concerned about a specific place, it gives us authority to investigate routine complaints. To enforce the rules that are promulgated underneath this law. It also gives us an authority, and this is, I think, an important one for anyone who's listening that is already in the field. Gives us our authority to enter an establishment to inspect that facility. They do need to be open and preparing food, but they do not need to be open to the general public. So this is an important authority when you get a difficult operator who may want to refuse you entry into a facility. So that in and of itself is a violation of the law. It also, again, gives the authority to the state to delegate these powers to local public health so that the state is not stuck trying to do all of this work themselves across the entire state. There's some other laws that we aren't going to cover today, but there's the Pure Food and Drug Law, and there are also laws around raw milk and cottage food, and we'll touch on some of those topics a little later, but there's other official laws that address some of those specific topics. So the Food Protection Act gives the state, again, the authority to put rules in place where the Board of Health then adopted what's called the Colorado Retail Food Establishment Rules and Regulations. So these are the minimum standards that a retail food establishment must follow in order to operate in the state. It really puts forth a charge for uniform statewide administration of these programs. So as Alicia said, not only do you see typically consistent efforts across the country, Colorado has a very specific charge and focus to make sure that we are implementing these at a local level very consistently. We want to interpret the rules consistently so that restaurants are being treated fairly and understand exactly what they need to do, especially for ones that have multiple locations across many counties. This is where we have our licenses issued are typically done at the local level. And so RFE, again, is our retail food establishments. We do resolve those complaints. We enforce those rules. And then, again, do our inspections and interventions for foodborne illness. And as I mentioned already, that the counties typically are delegated this effort. We have all this authority, so this is sort of a backbone, but it isn't really our significant approach. We really have the ability to be, if you will, the food police, but it's much more powerful to use influence and work with facilities. So instead of just relying completely on the law and the authority we have, you are often able to gain compliance through just working with a facility, and that applies certainly within an outbreak as well. So the collaboration and partnership are still really essential tools of how we operate. All right. So as I mentioned, we really do want to have a uniform program. So the state has been the leaders of that charge to ensure that locals really are all doing things consistently. So what we look to is at the federal level, they've created a national voluntary program standards for food safety programs. So that's what the VNPS is, the voluntary national program standards that the FDA has created. And it lists a number of topic areas where programs would want to model the work that they do after these program standards. So the standard number 2 focuses on the training of staff. So it sets forth a pretty rigorous training program to make sure the staff that are out there doing this have a very strong background to understand not only the rules that they're enforcing, but really the microbiology and the public health significance behind why we're doing what we do. And that's really essential to that collaboration and partnership. When you can explain the rationale of why someone needs to do something rather than just saying it's the law or the rules, that goes a much longer way for them to understand why this is important and important to their business to have a viable livelihood. It really sets our inspection protocols on the HACCP principles, which is a hazard analysis critical control point process, where you're really looking at what are the significant risks within a facility and how are they being managed. Our real focus is on rules that are focused on preventing foodborne illness. So we have risk factors specific to foodborne illness, specifically, worker illnesses. So we don't want sick people working. We want people not touching food with their bare hands. We want to make sure that food that needs to be temperature controlled is done so. So hot food stays hot and cold food stays cold. So that's the main focus of the work we do, is looking at those foodborne illness risks. And then it sets protocols and best practices for how you would deal with outbreak investigations. Those are 5 of the 9 kind of program standards that are most applicable to what we're talking about today.
So we're going to turn now to how we monitor foodborne illness. Thank you. So, because another key component of food safety is our ability to monitor foodborne illness when something goes wrong and then do something about it. So similarly to the way Lane set this up, we're going to talk about statutes and then regulations. So the communicable disease statutes or laws give public health both the duty and the authority to investigate and control the causes of epidemic and communicable diseases and conditions affecting the public health. That is really broad, right? That's a huge mandate. And so it obviously applies beyond food safety, but in the context of food safety, that is where our primary authority and duty comes from. And it's important to say that this authority is so broad and has to be used very carefully, and we strive to do that. Also of note, there are 2 different communicable disease statutes in Colorado. One gives the duty and authority to local public health agencies, and the other one is specific to the state health department. But the authority is the same for each. And I didn't know this before, but this is apparently not the case for some other states. And the citation on this slide is the statute for local public health agencies, but there's a similar one for the state health department as well. Some other key provisions of this are the authority to investigate and abate nuisances, to eliminate the sources of epidemic and communicable disease, so the ability to do something, and also the ability to make necessary investigations or inspections alone or with the state health department for matters affecting public health. So these are some of the 3 core parts of the statute that allow us to do what we do. There's a few other key parts of the statutes that I want to highlight as they pertain to food safety. In addition, state and local public health authorities are given the specific authority to use public health orders. So specifically, in the event of a public health emergency, and an outbreak could be defined as a public health emergency, the public health agency can issue orders that are consistent with the laws as the public health director deems necessary for the proper exercise of the powers and duties to control disease. Again, this is quite broad, and it is used very carefully. And in fact, it's very rarely used at the state health department in the context of foodborne outbreaks or foodborne investigations. But as you'll see later, it is used more frequently at the local public health agency level during investigations. And then further, we're not going to go through this one in great detail, but the statutes also give public health agencies the authority to administer and enforce those public health orders and authorities. And so that's very important, that they're given the power to actually do something about them and make sure that they're carried out. So turning to monitoring foodborne illness, specifically the laws are passed and then regulations are made to flesh out the details of the law. So in our case, in communicable disease surveillance, the Colorado Board of Health promulgates regulations to flesh out the details of these statutes. So the Communicable Disease Regulation 6 CCR 1009-1 is our communicable disease set of regulations. And in it, it spells out the details of which diseases we can monitor and how we go about doing that. And so part of the regulation spells out the reportable conditions that are deemed dangerous to public health. And in that, people with certain conditions must be reported to the health department. This disease reporting for something such as salmonella occurs without the consent of the patient. It doesn't require consent. Now, that doesn't mean that we're trying to do anything sneaky and not tell the patient that we're reporting, but certainly even if the patient doesn't want their information reported to the health department, this regulation says that it can still happen. In a disease report, there's some basic information that must be included, such as the patient's name, address, the phone number, and the laboratory information we need in order to know that, say, somebody with salmonella really has salmonella. And another very important part of the regulation is that the health department is tasked with maintaining confidentiality. And there's a whole section about confidentiality and making sure that we maintain confidentiality of these reports. We do surveillance for three main reasons as it pertains to food safety. The first is we collect aggregate data in order to see if the food safety regulations are having an effect or are making a difference. So, for example, after the FDA issues new requirements for salmonella enteritidis in eggs, they say how much salmonella enteritidis can be in 1,000 eggs, how many of those eggs can have salmonella in them. We monitor in order to see if there's a decline in salmonella enteritidis infections. So monitoring is absolutely key to this regulatory piece. The second use for monitoring has to do with preventing illness by implementing disease control around a single case of illness. So we use our public health authority to exclude certain people from their usual activities if they're deemed to pose a risk to other people. So in core public health, when we say that a child who is infected with E. coli 0157H7 can't return to childcare until that child is cleared of infection, has had 2 negative stools, we're using our public health authority for isolation and quarantine, which is a statute that I didn't talk about, but there's a whole separate piece for isolation and quarantine, particularly the isolation piece. And then when we exclude a food handler with E. coli 0157H7 from handling food until he or she has 2 negative stools, there's actually various public health regulations that apply to food handlers, both in the retail food regulations and in the communicable disease regulations that state that a food handler may not work while infectious with something that could then spread to somebody else. And then finally, we use that surveillance to detect outbreaks. So when we see an unusual number of cases of a particular illness, and we stop to investigate to determine its source.
All right. So now we're going to give you some real-world examples of what we've dealt with. And here's this is going back now a while, an outbreak we had in 2008 in Boulder County of E. coli 0157H7. And so this really originated at CU. So we had information from the student health center there and several students that were ill, bloody diarrhea and cramping, and some linkage to a sorority. And as would always turn out, this happened to be during sorority rush, so there was a significant event at that sorority. So this luckily turned out much better than I think it could have, given the hundreds and hundreds of young women that went through this facility during that weekend. So as part of this effort, when we have a suspected outbreak, which for us, a definition of an outbreak is 2 or more illnesses from not from a common household. So when we see these reports coming in, which is kind of the scenario that we had here, that kicks us into a different mode. Instead of just a disease investigation, now we're concerned that this could be a more widespread and a bigger issue. The healthcare provider, as Alicia mentioned, was following the requirements to report these illnesses. So E. coli is one of those listed required reportable diseases. So we had kind of 2 suspected E. coli illnesses from that sorority, and that started us into this investigation mode. Thank you.
So, excuse me. So in addition to stipulating what is reportable, the communicable disease regulations also spell out what public health can do when an investigation is needed. And it's very important to say that they spell out that an investigation may include but is not limited to the following. And so here are some of the relevant ones. One is performing follow-up interviews with the case or persons who know about the case. So you can interview the patient or a proxy. Review of relevant medical records, and again, you don't need patient consent to do that, and that's a very important part of the rule too. And again, it's not trying to be sneaky, it's trying to expedite things so that we can go and look at a patient's chart if we need to without going through the sometimes week-long process to get the patient's consent. Medical testing of a person, obviously with their consent in that situation, that might include obtaining stool specimens from people who are ill. Administering surveys to ill people or people who could have been exposed, so that includes our case control studies that we do. Taking photos, obtaining samples, and similar to the regulation that Lane cited before, entering places of employment in order to investigate. Something that hangs up a lot of communicable disease investigations is the question about whether we can get the list. Right? So whether it's a wedding and we're trying to get the list of participants, or whether it's a reservation list at a restaurant, or possibly receipts from people who purchased foods at a restaurant, the communicable disease regulations specifically address this. And what they say is investigations can also include obtaining from public or private businesses or institutions the identities and locating information of persons, travelers, passengers, or transportation crews with similar or common exposure to the infectious agent as a reporting case. So the example of that is, it's totally within our communicable disease regulations to say to a restaurant, we want your reservation list for the days of concern because we want to call those people and find out if they're sick. And sometimes restaurants have pushed back against that over the years.
So when we were doing this investigation, these were kind of the basis of what we were looking at as our authorities. And given this, we're talking about some sensitive issues anytime we're dealing with an investigation. So now we have a sorority who's going through rush and certainly doesn't want to become the headline as the source of a large outbreak in our community. So we started our investigations and looking at the sorority house as our initial place and getting information of what happened during that event. And again, it really scared us knowing that 800 or so people may have gone through and had a chance to partake of food that was being offered there that was both provided by the sorority and catered. So we had the potential for something much bigger than it ultimately turned out to be. But met with the facility, met with the people who helped run that, and really started looking at what were the foods that were provided during kind of that incubation period for when the people were sick, and started interviewing the cases as well as others who may have had common meals. But we really everything was initially pointing to this sorority, as we had multiple illnesses now, in addition to the confirmed or the people who had already been reported to us. So we really wanted to see what the linkage was there. So again, starting to look at foods. Again, we have the authority, but this is not where we're invoking these at this point. We want to cooperate with them and, again, do our best to keep this as low profile as we can. So as I mentioned, so we've gotten a bunch of food and a bunch of people who've potentially eaten it. So we really wanted to look at what were those common food items that may start to point us to what was the cause of this illness. And that started leading us to some retail food establishments in Boulder that had prepared food for their event. So we had food from a sub shop that we will remain nameless, as well as a pizza facility. And again, a lot of people who were doing this. The other interesting piece is they had done what they call a lockdown. So people were staying at the sorority for an extended period of time during this. So they really were all having very common meals, as opposed to going back to maybe where they were staying or having lots of outside meals. So that's good and bad. It gave us a stronger picture of what the potential food items were. So we sent our staff out, the trained environmental specialists, to look at the kitchen at the sorority to see if there were practices there that could help contribute to an outbreak, as well as, again, mobilizing our communicable disease folks to interview the ill sorority members. And then we're also getting some additional reports of illness, and again, looking at common elements there. And again, we already had some sources of the food provided, again, a sub shop, and that sub shop became also linked to some of the other suspect cases that we had in Boulder County. So we started looking at kind of the pieces of the puzzle there and began to move our attention to the sub shop. So we started looking, and we actually had 4 different retail food establishments that had provided food. So we went to all 4 of those, and ultimately then began to focus our attention on sub shop A, as that became one of the stronger links. So what we do during a routine inspection, as I mentioned, is we're looking at sort of our broad rules and looking at foodborne illness risk factors. When we get into a disease investigation, now we're really looking at food flows, the food that came in, especially when we have suspect food items, how that was handled, who specifically handled it, so that we can see, is there any linkage to what happened in this restaurant to the outbreak that we have going on. So during that investigation, we started to, again, look at different food items that were part of the menu items that people had eaten. So we're looking how those were handled specifically, and we did see some observations in this facility that were problematic, so that could allow for additional risk for foodborne illness. The sub shop was not cooperative, so we did try to use our influence and try to work with them. A power that I guess is not granted specifically in any of the statutes or rules, but one that is very influential, is the ability to let the public know what's going on. So as a restaurant, that's not the headline that you want. So those are other things that we can do to influence cooperation, and we were urging this facility that we really wanted to see their cooperation as opposed to making broadcast press releases. Unfortunately, we did need to do some press releases because we had ongoing illness in our community, and the facility wasn't ultimately cooperative. So we started to move up the chain of our authorities, and we did end up invoking some of our public health authorities to issue orders. So we issued orders to the facility initially to have very specific handling of food, very specific glove use and hand washing, followed up by specific requirements for their staff to be tested to make sure that they didn't have any ill food handlers at the facility. Again, unfortunately, they were not very cooperative and responsive to that. We also had required them to inform us if they had any ill employees. Upon our subsequent investigations, we identified both people that were now reported as ill through the disease requirements, as well as through our interviews of the staff. So they had a number of ill food handlers that were still working at the facility. So at that point, we did order this facility to close. And at that point, now we definitely had their attention, and there was a change in heart and definitely stronger compliance for that. We focused on this facility now being a potential vehicle, not the only one, because as the investigation unfolds, there's additional information that always continues to come in, but really have a deep cleaning of this facility. All of their food that had been out needed to be discarded. They needed to only use staff that were confirmed to not be ill to come in and do the cleaning and any additional handling in the facility. So that was really our focus. So the facility ended up being closed, I believe, for 4 days till they finally had all of these conditions met, and then they were allowed to reopen. So in total, being a busy place and having staff that kind of moved around from franchise to franchise, we interviewed 42 of the 43 staff that were involved at working at that facility and collected swabs from those employees to determine which people needed to continue to be excluded or who could be cleared to return to work there. And again, this is where we did invoke those broad communicable disease authorities and the authority granted to local public health agencies. We did collect food. Here's a little picture of what we believe to be our culprit, but we're not able to confirm that. And that's yes. So Alicia and I were joking about that and making sure it was not the same sub shop that catered today. So it is not. So for those of you who've eaten, hopefully you're all safe. But Sprouts have been known to be linked to many E. coli outbreaks, and this was a significant linkage in our investigation. Typically, it's very rare to collect food samples that ultimately test positive. And there's a lot of reasons for that. One is the bulk of food that go through a restaurant. Often by the time we're investigating, the food that initially was being served is long gone, so there's really no continuation of that food. So that's one of the big reasons. But we're not still 100% certain whether the food started it or a sick person started it and transmitted it through food, or what the ultimate source was.
So, excuse me. As Lane alluded, outbreaks tend to evolve as they're investigated. This outbreak started as it looked like there was illness from a single catered meal for the sorority. And then as additional information came in, it appeared that there was illness from a single sub-shop because one of the cases didn't attend Rush, but still ate at this particular franchise. And then we identified ill workers at sub-shop A. But then we decided that it was illness from a food item served at Chain A because as the investigation evolved, there were some additional cases that had the same DNA fingerprint of E. coli 0157 who ate at different locations of the same franchise. So then we started looking at potentially a contaminated food item that had more widespread distribution, and there was illness among Chain A patrons as opposed to just sub-shop A. So as the investigation grew, so too did the partners and the investigation activities. So at this point, some additional partners were added. Partners from the State Health Department, Environmental Health Division. The epidemiologists were assisting, giving not much technical support to Boulder because Boulder was already completely autonomous in doing this outbreak investigation. We were aware of it. But we brought in our environmental health colleagues as well as contacting the Food and Drug Administration. And two additional activities occurred. One was a traceback of certain implicated ingredients. So Boulder County Public Health conducted a cohort study, and alfalfa sprouts, lettuce, and tomatoes were all statistically associated with infection. And so a traceback occurred in order to trace those three produce items back to see if we could find a common source. That traceback is usually coordinated by the State Health Department and FDA. FDA has specific laws and regulations that allow them to perform a traceback. And at the State Health Department, that traceback authority is part of the Pure Food Act. It's one of our Food and Drug Act. It's one of our laws that we operate under for food safety at the State Health Department. So we both had specific authority to be able to collect this traceback information, which includes collecting invoices and purchase records from various establishments going up the food chain. And then the investigation occurred at the sprouter. The Food and Drug Administration regulates sprouters, which is the place where you take sprout seeds and sprout them to make sprouts, as their product crosses state lines. And so they investigated jointly with CDPHE and collected samples for testing and reviewed procedures at the sprouter. In this case, in this outbreak, there was no recall. The product had already moved through by the time we were investigating and the outbreak ended. No clear source was identified, although as Lane said, we strongly suspect it was the sprouts for a variety of reasons, including the distribution of them and the food histories that we obtained from patients, but it wasn't entirely clear what happened in this particular outbreak. So when the outbreak is over, everybody's natural inclination is just to move on to the next thing, but there were a few more steps in this outbreak, as there should be with all outbreaks. We all try to document what we did and why so that there's lessons for the future. And from a legal regulatory perspective, our outbreak reports do not contain personal identifiers because they are public records. And so we would never release publicly people's identifying information. At CDPHE, our policy, however, is to name the facilities involved in an outbreak, whether it's a hospital, whether it's a retailer or whatever, so that is in the final report. And then the higher profile outbreaks, as this one was, tend to result in requests for information from a variety of sources, including the media, lawyers, people who are affected, you name it, people will ask the health department for records. And so there's two categories. One are individual record requests, and the record release is clearly dealt with in our regulations and our statutes, that records that are made under public health reporting regulations are confidential. There are limited situations when that information can be released, and clearly we can release patient information to the patient to whom it pertains. We have a whole policy at the State Health Department about how we do that. It basically involves getting a notarized letter from the patient, and if people have specific questions about how that works and how to get data out of CDERS, we have a protocol document on the CDER's main menu for those of you who use our communicable disease database. But the gist of it is we don't release that to just anybody. We only release identifiers to the person to whom it pertains. Open record requests are a whole different animal, and that could be a whole talk unto itself. They can be very broad under the Colorado Open Records Act, or CORA. They can include almost everything except identifying information. There's a specific time response for how quickly you need to get back to people when there is an Open Record Act request. And what I would say about the rest of it is, if you get an open record request, we always hand them right over to our legal staff at the State Health Department. Lane is nodding that that's what happens at Boulder too. And so if you're a local public health agency with questions about those, you can certainly contact us and we'll talk to you about it. But really it comes down to call your lawyers right away.
So I had alluded to a few other kind of laws and regulations that we have in Colorado that make for a more unique world to navigate. And some of you may be familiar with some of these topics. But cottage food has been something in the last several years that's really grown. So there was a law passed in Colorado that allowed people to make certain food items in their home and then sell those directly to the public. So that law exempted them from following the Colorado retail food regulations. So they don't need licensure. They don't have to follow those specific food safety practices. It does require them to get some training, and it does require them to have a label on their food item. And initially, that list of foods was focused on what we would consider not potentially hazardous foods. So things like baked goods, jams and jellies, candies, honey. It did allow for small egg production, but other than that, it was focused on foods that in and of themselves don't have the intrinsic food safety risks. However, through food handling, if you're ill, any food can be a vehicle for disease. So this rule starts to push the line of public health comfort in our state, but that when we have issues with cottage food, there's a whole, again, exemption and specific requirements that we would not be able to invoke for cottage food. Raw milk, so this is unpasteurized milk. This has been an unfortunate trend, in my opinion, across this country, where we've seen one of our big public health victories of pasteurization being unlearned. And so we have allowed in Colorado, so now for several years, people to become part of a share, meaning that you own a share in the herd, either a cow herd or a goat herd, so that the products from that herd are entitled to the shareholders. So this allows then the transfer of raw milk, unpasteurized milk products to people that are shareholders. They, again, don't have to follow any of the retail food regulations. They are not bound by any food safety standards. They do need to, again, label their product and let people know that what they're buying is unpasteurized. And if in the event they're doing any testing, they should be sharing that with their stakeholders. And this is, again, as Alicia said, a whole nother talk of outbreaks and investigations and things like that. And then in Colorado, we have a wonderful spotlight on marijuana. So we have already seen this prior to the recreational marijuana, but with medical marijuana, but marijuana being infused into products. So there are separate now statute and regulations. And this, unlike raw milk and cottage food, actually has pretty stringent regulations. So the State Department of Revenue is the initial regulating authority for following through on marijuana and its infused products. And we've seen that really spread the gambit. So any kind of food item you can think of has been infused. And once it's infused, it's no longer considered food. So under the federal and state rules, that would be considered an adulterated food by adding that ingredient. So it is dealt right now very specifically under the marijuana rules and regulations, but they do have hygienic standards and requirements in those, and there are some references and efforts to look at what the retail food requirements are on those.
And then, excuse me, finally in the list of other is healthcare facilities. And healthcare facilities include things like nursing homes and hospitals and assisted living facilities. Their kitchens need to follow the same retail food regulations as do restaurants and whatnot. However, the inspection's a little different, so we figured we'd highlight them. They are inspected by the State Health Department Health Facilities Division, so it's a different crew of inspectors their inspections are less frequent than retail food establishments. And then if they also serve food to the public, some local public health agencies will inspect those kitchens as well. So the regulations are the same that they need to follow, but the process is a little different for healthcare facilities. But one point I want to make about cottage foods and marijuana and raw milk and healthcare facilities that's very important is that while the regulations to prevent disease in those facilities or the way they're carried out is different, the inspection and the duty to investigate is the same. And so even if those facilities are not regulated in the same way and there isn't the normal rapport, say with Lane's group from Boulder for routine inspection, when an outbreak happens, we have the same authority to go in and to request the same records and to take the same actions. And that's a very, very important step to mention. So we still have the duty and authority to control epidemic and communicable disease, even if we didn't have it to prevent the disease in the first place. Okay? And so with that, I think we have time for questions. I'm not sure the best way to handle it. Maybe we start in the room.
For questions, for the people online, post them in the chat box and then I will relay them. And why don't we start with questions in the room and I'll pass the mic to people who have questions. Sorry, give me just a sec.
We can always repeat the question for you.
So I'm interested in the microbiological aspect of determining what the source is and how long it takes. And so for the example you gave in Boulder, the first information was given to you by the physicians that saw these patients. And then once you get this information that it's listed as an outbreak, how do you go about identifying what the organism is? Is that the most important thing in how you investigate the outbreak? I mean, you mentioned that the DNA fingerprint was the same as something that you saw in another food source than the sprout. So obviously you're looking at it by a PCR to determine what it is. So if you could, you also mentioned that all the food was thrown out at this facility. Is that, I don't know if that was what I heard that correctly, but is that something that's routine regardless of whether you've identified what the organism is that's causing the illness or not?
Yeah, thank you. Good questions. So this, not all outbreaks start the same way. This one, as we mentioned, came as a reportable disease. So in that situation, we know the pathogen of concern. So we already knew we were dealing with E. coli. So that's how that one started. And then through any outbreak, there is PFGE matching that's done to confirm our people seeing the same exact strain. So that was what linked us to other counties where we saw, again, people as part of the same chain sub shop, as well as other people who had this illness who hadn't had any confirmed meals at that sub shop. So in that case, we already knew what the pathogen of concern was. And whenever we have then the pathogen of concern, that's a great leap forward. So now we know incubation periods for that disease, and that starts to look us back when we're looking at food histories. What meals did they eat when they likely were exposed to E. coli? And so with E. coli, we were looking at that kind of 2 to 5 kind of or so day window, and it fell very significantly right at that rush event. Obviously, we looked at all the meals that were in that, which led us to those 4 total establishments, in addition to the meals that were served at the sorority. Let's see, you had a couple other components in that.
So one of the things we'll say too is we're happy to talk about the process of outbreak investigation later, but we want to make sure we focus on legal things. But the question too is about whether throwing out food is common, and the answer is sometimes if it's been missheld, as in this case it was.
Yeah, I think the other significant events that happened at that facility is they had a pretty significant number of ill food handlers that were working at that facility, after we had given them requirements to really make sure that they were reporting illnesses to us. So we had great concern about all the things that were handled in that facility. So when you're thinking of a sub shop, lots of items that are now potentially handled in order to get them into the various reach-ins and cold tops that are being used to assemble in a mass scale restaurant. So that was the other concern is how widespread was this, given that they have ill people that have maybe handled and mishandled a lot of different things. So it is not typical that we would just go in and throw out the food, though.
So we have a couple of questions from the online folks. So the first is, what if a health order is refused?
So now this is a law. So if you're refusing that, that is obviously breaking the law, if you will. So now we can invoke our legal folks, at the state and local level, and then bring the courts into this. So then it would become a court order to follow the public health requirements. And now if they do that, they're in contempt of court, which has jail time and other fines associated with it. So typically it doesn't go past that, but that would be the next steps, would be bringing in a court order that if they violate any of these conditions, and it would happen very quickly because public health is taken very seriously, and it would not take very long to get that, as much as the legal process sometimes can be very cumbersome. Now we're talking about stuff that's pretty imminent danger, so we would pursue that route.
Great. So the second online question is, we at DEH have been using the food safety regulations to regulate marijuana products. I'm confused why the slide says marijuana-infused products are exempt.
Yeah, and I should have mentioned that. So when we talked about our rules and regulations, so the Colorado Retail Food establishment rules and regulations apply everywhere in the state with the exception of Denver. Denver, as a home rule city and county, has passed their own rules and regulations. So I'm not sure if they're using exactly the food or that their marijuana regulations basically mirror their food regulations. But so they have their own separate regulations that apply. They also issue their own food licenses. So the Denver operates just a little bit differently. Their rules largely mirror what the state rules are, but they are home rule.
All right, we have a couple in the classroom, and if anybody else online has more questions, please continue to post.
Thanks for a great presentation. If you go into a facility and you find some food workers who are ill, who need to be removed from food handling processes, what happens to their pay? Is that something that's necessarily covered by the employer? Is it optional?
It's not covered by the employer.
Okay,
and so we try to work, in general, we try to do the minimum necessary. So sometimes if it's just a few, we'll try to reassign them. We'll get them to do non-food handling activities. We'll try to convince the employer to continue their pay. It's a huge issue because most workers in food service establishments don't get sick time.
Right. And that's kind of where I was going with this, because I know that recently there was a law that was proposed or something that got voted down, and so the law would have required establishments to offer some sick time. And I'm just curious whether you know of any evidence from other states that have implemented similar laws, whether there's any evidence that sort of how that impacts actual foodborne outbreaks.
I haven't seen any studies recently. I know that some states have recently done that in some municipalities, but I have not seen data yet to see if intuitively it makes sense. We know a lot of workers work while they're ill because they have incentives to work, but we don't know if there's data behind them.
Thanks.
No, I don't. We know, as Alicia mentioned, ill workers is a significant foodborne illness risk. So if we can find ways to set policy that can really address that, and that's a very significant one that public health is very much behind, even though it, on the face of it, doesn't seem to make as much sense that we are so focused. But as Alicia alluded to, is if you're not going to get paid or you have the potential to lose your job by not showing up to work, you're going to show up whether you're ill or not. And when you're in this kind of occupation, as several others, it's a huge danger to the public. So there's huge public health reasons why people should have better wages, living wages, as well as having paid sick leave.
And sorry if I'm monopolizing the time. So is there any indication that, is there any way of tracking whether people do lose their jobs if they are found to be carrying some sort of foodborne illness?
There's no formal tracking. I would say that we have heard of some sometimes, but more often they can work with their employer.
Mm-hmm.
Yeah.
Okay, thanks.
Thank you very much. I have a question on the prevention side of things, and you many times said you had the authority to do this, this, and this. How well are you funded to do those inspections? And, and also is there funding to do, prevention types of education, that would, I just think of all the different restaurants there are around and maybe the quality of what I've seen of some of the folks who are working and owning and all that. And I just wondered if you feel like there's an adequate, I put you on the spot.
No, it's a wonderful question. It's like I planted it there, and especially if we can get this to our state legislators. We are not adequately funded, and so the things we describe in outbreak, that's really all additional workload and pretty significant resources that get poured into that. But just the routine work to do that prevention base is dramatically underfunded. I would say it's maybe at best half the funding that's really truly needed. So I talked earlier about the federal government, the FDA has set sort of model program standards. One of the standards I didn't put in the talk is talking about the resources needed to run a program. So we've done some good analysis in Colorado to see where we're at. And the only people who are able to keep up are basically, having their staff do probably twice the work of what is really reasonable to do. So that starts to compromise the quality that you can get done. And it really compromises the ability to do anything extra. But education and putting resources into that, to me, are very important. So a lot of locals still try to put effort into that and provide training for restaurant staff to understand basic sanitation and foodborne illness risks. We've leveraged online resources to provide training like that so that people can do it at their own pace and in multiple languages. But turnover is a significant issue at restaurants. So when you're dealing with a new staff pretty regularly, putting that focus into training becomes even more important, but it's again areas where when they're busy, that's not always where the attention goes. But yeah, we need a lot more resources. Typically, a local health department gets about 40, maybe 50% of its revenue from the license fees, and then the rest from county contributions. And that's for a program that needs twice as many people as it actually has. So we need a lot more funding, and the restaurant has a very powerful lobby that is very resistant to increasing their fees, which in the state of Colorado average around $250. So we're not really asking for a lot of money to make, in my opinion, pretty significant shifts in prevention. But the public doesn't know these things, and that's somewhat our own fault that we don't tell the tales that we need to, because the public is the biggest ally you can ever bring to the table. So
I don't think we have anything else online. Oh, another couple of questions here.
You mentioned earlier protecting the privacy of some individuals, whether after they've been diagnosed with a particular foodborne illness. In the case of the Sub-Shop A case that you guys took care of, where you had 40 some, I think you swallowed about 40 individuals, and you had a couple cases of, I guess, not healthcare workers, food workers that were ill. In that case, are the individuals, their diagnosis, is it revealed to the employer, so that the employer can ensure that that worker is not coming to work while they're sick? Or is privacy thrown out the door in that case, or do you maintain that patient confidentiality and privacy?
So the regulations and the statutes say that release can be made as necessary in order to protect the public's health. And so we follow HIPAA-like standards in the sense of we release the minimum amount of information necessary. In the context of an outbreak where you're working with Sub-Shop A's management, you pretty much have to say, so-and-so cannot return to work until cleared by public health. So we do the best we can. We certainly don't disclose that beyond the people who need to know, but in this case, the restaurant management needs to know so that they can take action. So it's not throwing it all out, but we definitely we disclose the least amount of information we can to do what we have to do.
Maybe we have time for one more quick one.
So I don't know if you're aware of this, but one of the local television news stations does what they call the restaurant report card, which I find very interesting when I read. Do you think that's a good thing? And how do they get that information?
Yeah, I think the public is a huge advocate that we need to bring to the table. So when people are more aware of what really happens, I think it does shed a light, because I think everyone assumes if a facility is open, they must be doing a great job. And our rules are pretty difficult to navigate. You know, the power to close a facility is focused on sort of imminent health hazards. So just something that's more routine risks, violations that are happening, they need to be pretty consistent over an extended period of time before we really are able to invoke powers to actually close a facility. It's a pretty long, laborious process that's called our civil penalty process. So I think the public really needs to know more. And a lot of jurisdictions are putting their restaurant inspections online. So those are vehicles where, as Alicia alluded to, a lot of our records are available to the public. The specific health investigation stuff is a lot more confidential. Routine inspections are not. There's very little that's in there that's confidential. So most jurisdictions are trying to share that so that the public is aware who is doing a good job and who isn't. So, and again, I think there's a lot of places that do a good job, but there are several that don't. So, and it's important to know where those are so the consumers can make informed decisions on where they're going to eat. Because again, their dollar is probably a stronger motivation than our inspections to get them to really shape up. If people don't eat there, then their business really doesn't stand a chance.
Great. Thank you, everyone, for participating, and thank you very much to Alicia and Lane.
Turn on.